My name is Yeleny Pereda.
And I am Andy Vazquez.
We are both senior student registered nurse anesthetists at Franciscan Missionaries of Our Lady University, and this is our DNP project. We have conducted a systematic review on the use of Neostigmine and Atropine for prevention and treatment of post-dural puncture headache. A post-dural puncture headache is a headache that occurs within 5 days of a dural puncture. A post-dural puncture headache is a complication which can occur after the administration of spinal anesthesia, inadvertent dural puncture while attempting to insert an epidural catheter, or while performing a lumbar puncture. Obstetric patients are most likely to suffer from post-dural puncture headache from neuraxial anesthesia. There are 3 proposed theories for the cause of post-dural puncture headache. The first theory states that intracranial hypotension caused by the puncture results in meningeal vasodilation and blood volume expansion, leading to a headache caused by the acute venous dilation. The second theory states that intracranial hypotension can cause drooping of intracranial structures and cause stretch on the intracranial nerves, which leads to pain and cranial nerve palsies. The neck, back, and shoulder pain may be caused by traction on the upper cervical nerves. The third theory states that a lumbar puncture leads to altered craniospinal elasticity, which results in increased caudal compliance and acute intracranial vasodilation in the upright position, which leads to pain. There are currently no set guidelines on how to treat a post-dural puncture headache. Conservative management consists of supportive therapy, which includes bed rest, rehydration, abdominal binders, oral caffeine, and analgesics. Invasive measures include epidural blood patch and intrathecal catheter placement. The most effective treatment for post-dural puncture headache when conservative measures fail is an epidural blood patch.
The neuromatrix model of pain suggests that the central nervous system produces pain rather than the periphery. A CSF leak causes drooping of intracranial structures and stretching of the intracranial sensory nerves. The stretching of intracranial nerves causes pain and cranial nerve palsies. Magnetic resonance imaging studies of downward displacement of the brain were related to headaches and resolved alongside the headache symptoms. PDPH-associated symptoms, such as back, neck, and shoulder pain, might be triggered by traction of the upper cervical nerves. The neural matrix consists of several areas within the CNS that contribute to the signal, which allows us to feel pain. The sites include the limbic system, spinal cord, somatosensory cortex, prefrontal cortex, brainstem, thalamus, motor cortex, and insular cortex. Together, these areas in the CNS work to allow an individual to feel pain. This collaboration is referred to as the neural signature. The neuromatrix philosophy also states that input from the periphery can begin or stimulate the neural signature. However, these peripheral signals cannot generate a neural signature of their own. The neuromatrix theory can help us understand how pain is independent of periphery or tissue damage.
A post-dural puncture headache can lead to longer hospitalizations and increased healthcare costs. Obstetric patients are most likely to suffer from post-dural puncture headache related to neuraxial anesthesia. Maternal neonatal bonding is compromised due to the discomfort, pain, and suffering caused by a post-dural puncture headache. Post-dural puncture headache can be debilitating to mothers as it interferes with their ability to care for themselves and their newborns. Regional anesthesia is accountable for approximately 1/5 of professional liability claims in anesthesia. The incidence of post-dural puncture headache after spinal anesthesia is usually greater than 3%, but may occur in up to 9% of cases. Many measures have been recommended to help prevent the complication, but thus far none have been shown to be effective in randomized controlled trials.
The inclusion criteria for the review consisted of adult patients who were administered neostigmine and atropine to treat or prevent a post-dural puncture headache. Children were excluded from this review. Multiple synonyms were searched to have a concise review of the literature, which are shown in this image. 2 studies were included in this systematic review, both which are randomized controlled trial. Mamount et al. Conducted one study of 85 patients between the ages of 20 and 40 with an ASA status of 2. The other study by Abel Mabaun consisted of 120 patients with an ASA status of 1 or 2. Both studies were conducted in Egypt.
Two doctoral nurse anesthesia students conducted a comprehensive and systematic literature exploration to thoroughly review research regarding the use of neostigmine and atropine to prevent and treat post-dural puncture headache. The preferred reporting items for systematic reviews and meta-analysis or PRISMA protocol was utilized. The search engines that were used were Medline, ProQuest, Sino, Cochrane Register of Controlled Trials, Cochrane Clinical Answers, and Cochrane Database of Systematic Reviews, and Cochrane Methodology Register, JBI EVP Database, Science Direct, Google Scholar, and online search. Limiters included peer-reviewed publication dates between January 2000 and September 2022. The 2 doctoral students and the Franciscan Missionaries of Our Lady librarian collaborated to confirm the extensiveness of precision of the search.
The literature search resulted in 104 articles. The title and abstract of all 104 articles were read. 100 articles were excluded due to not matching the research question. Of the remaining 4 articles, 2 of the full text articles could not be acquired due to the journal only providing the abstract. The students individually appraised the remaining 2 articles using the Joanna Briggs checklist for critical appraisals. Both students agreed to include the article in the systematic review because both studies aligned with the PICO question.
Mahmoud et al. Conducted a randomized controlled double-blind study comparing neostigmine and atropine versus a saline placebo for treating post-dural puncture headache alongside supplemental management with hydration and analgesics. Primary outcomes were the differences in the visual analog scale before intervention and 6, 12, 24, 36, 48, and 72 hours after intervention. Secondary outcomes were the need for epidural blood patch, vomiting, nausea, and neck stiffness. The sample size was 85 adults, which were divided into 2 groups with no significant differences in characteristics amongst both groups. VAS results were considerably lower in the neostigmine atropine group than in the placebo group between 6 and 72 hours. Every participant in the neostigmine atropine group reached a VAS greater or equal to 3 after 2 doses. None of the patients in the treatment group experienced a headache or received an epidural blood patch, since they did not report a VAS equal to or greater than 5. In the placebo group, 7 participants or 15.9% were treated for constant post-dural puncture headache and a VAS equal to or greater than 5 after 72 hours.
Abdel-Maboun conducted a randomized controlled comparative study to measure the effectiveness of intrathecal catheterization, epidural blood patch, neostigmine/atropine on preventing post-dural puncture headaches. 120 adult patients participated in the study. The 120 participants were divided into 4 equal groups: a control group, a neostigmine/atropine group, an intrathecal catheter group, and an epidural blood patch group. Participants in the control group received conservative treatment such as supine or prone positioning, hydration therapy, bed rest, abdominal binder, and 75 milligrams of diclofenac after developing a dural puncture headache. The pain was measured using VAS scores at 6, 12, 24, 36, and 48 hours post-intervention. The control group demonstrated the highest VAS score with a major difference over the other 3 groups. The number of patients needing rescue diclofenac analgesia was the highest in the control group.
Limitations in the study by Mahamoud et al. Were that all participants received conservative care, all participants were an ASA score of 2, and the study was only conducted in one hospital instead of multiple different hospitals. Limitations in the study by Abdel-Maboun included that all participants were only ASA scores of 1 and 2, and the study did not state if those who were conducting the study were blinded to group allocations. Strengths in the study done by Mahamoud et al. Were double-blinded randomized control trial, low risk of bias based on the Crochane risk of bias tool, published in a peer-reviewed journal. There were no conflicts of interest declared by the authors, and there were sufficient participants included in the study for reliable outcomes. Strengths in the study conducted by Abdel-Maboun et al. Included that the study had an adequate sample size, patients were randomly allocated into the groups, and no conflict of interest was reported by the authors.
Based on the results of the study, we can conclude that neostigmine and atropine can be used to treat and prevent post-dural puncture headache. However, further studies must be conducted. Implications for practice. Based on the available research on using neostigmine and atropine to treat or prevent post-dural puncture headache, a practice change cannot be recommended. Even though both studies showed positive results, there is insufficient evidence to recommend a practice change at this time. At the time of this systematic review, only 2 articles with a combined total of 210 patients have been studied on this topic. Implications for research. Implications for future research include multi-site, double-blinded randomized trials with larger sample sizes on testing of neostigmine and atropine against a control group. The neostigmine and atropine group should not receive conservative treatment during the study period to adequately test the intervention. Research should be also conducted on ASA 3 and 4 patients who can tolerate receiving the medications without complications to assess their use in clinical practice. Further research must also be conducted to understand the mechanism of action of neostigmine and atropine regarding CSF production and how it may stop a post-dural puncture headache.